Now we wait. Now we wait, and yeah, that should be good. Now, what I will probably do will be...
Nobody play any copyrighted music.
Yeah.
True. Definitely don't want to do that. Okay. How do I see all the activity? Yeah. I'm sure there will be, as usual, like a bunch of people that kind of trickle in, plus a lot of natural like YouTube followers. And so, yeah.
You started the video?
Yeah, it started. Now we just wait.
Are we in pre-lobby or is there a lot of...
No, we're live.
We're live right
We're
now?
actually live, yeah. Live chat.
Wow.
Live chat is up, you know, just waiting to see. Oh, hello. We can ask anything. Hello, Lynn. Yes. Yes, we're gonna get to the portion where we do answer questions. But we're gonna first kind of highlight a few things to kind of set the stage. It should be pretty short. We each have a certain topic we're gonna be going over, and then we're just gonna let everyone ask questions, getting to the answer one at a time, maybe even more than one at a time. No, one at a time. It'll be one at a time. And let's see. Nice. So we're gonna wait. We'll get started in like 5 minutes. But in the meantime, for the people that are already here, why don't you let us know like a little bit more about where you guys are at, a little bit more about maybe like anything that you're willing to share regarding like where you're feeling it. Maybe I should like pull up the like a pain pattern chart, and you know you can kind of let us know where exactly you're feeling it in reference to this chart. I have a P1, P2, P3. Where's that one? I have them labeled somewhere.
We got back burner with a number 2 thumb pain.
Number 2? How does he
wait,
know?
No. What is this little crown number 2? These are number 2 top fan?
Yeah, obviously.
We got number 3.
Yan our number 3 top fan.
Yeah. Oh, he's surpassed number 1 now.
I don't know what these little crowns are.
There we go. Found it. Found the picture. I go to photos. And what I do is I'll add image source. Pain patterns. Okay. And then I load up the image file while we still wait. And I can show everyone. Everyone can let us know where they're feeling their specific pain. Ooh, there it is. Boom. You guys like that? There it is. There's the numbers. Drop in the chat. P what? And how long you've been dealing with it, and maybe for
P
bonus, what do you think is going on? And you know, we will get to all of this. Now, wow, yeah, 15 viewers, great. Really appreciate everyone coming
Getting
through.
some love here from Balfrey.
Yeah. Wow, awesome. Really happy to hear that. That's definitely the reason why we do it, so we can try as much as possible to give people a lot more clarity around why they're dealing with what they're dealing with, and hopefully, you know, for the most part, when you deal with these things early on, learn how to actually get rid of it on your own. But you guys will learn as we kind of talk more about it. we definitely prioritize our work with a lot of individuals that have more of the persistent or chronic pain presentation. Um, I did download. I have been playing Star Fox on the Switch too. The nostalgia doesn't hit as hard as I thought it would be, but
Yeah.
I still love the game. I've definitely did many barrel rolls. Slippy is like still just as annoying. So,
Do they have a
yeah,
multiplayer version in that one? Because I remember the one for the GameCube was awesome because you could like do split screen like multiplayer and play against each other,
yeah, for
and it
sure.
was so sick.
I think you can. I don't remember actually. I don't know if this new one has it, but I thought they had it in the original N64 too, right? Am I wrong?
Yeah, but this one you could actually like land and get out of the like, and you can get into different vehicles and stuff, and you could run around instead of just like the R-wing fights.
Oh yeah, dude. Yeah, you can get in tanks.
Yeah,
I
you get
think
in tanks.
I
There's
remember
like
that.
different guns and stuff. Yeah, it was nuts.
Dude, it's wild. I remember playing that. I don't know if it was on the first one. Man, I played that. I spammed that game. Did you guys beat Star Fox? Have you guys played? You guys played it, right? Like,
Yeah, I
I never
remember playing
touched
the
it.
original. I don't remember if I beat the original or not, but I remember like 100%ing the one for the GameCube.
oh, nice. What was the last game you guys 100%ed?
Oh my God.
Do you guys remember? When the
Uh,
passion took
probably,
over and you're like, I need to fucking 100% this game. I love everything
yeah, I
about
mean,
this game.
it's been all MMOs and like PvP games for the past 15 years at this point. So
That's true. That's true. I
Maybe
think the
Black
last
Ops 2 Max Prestige.
really?
That might be the biggest
Wow.
one.
You
The
100%
latest
that.
one.
That's kind of crazy. For me, it might have been like, dude, it might have been like the old school games. I mean, the Final Fantasy, like Final Fantasy 10 was like a big one that I really, really remember fully just like 100%ing. Obviously like Ocarina of Time, that was a
yeah,
banger.
I mean, I played Breath of the Wild, but I wouldn't say 100%ed it. Like
I
I
definitely did
definitely
not
did like
100% that.
most things to do, but yeah, it was too much.
Yeah, I was like, there's no way I'm fucking doing every shrine.
Yeah.
Fuck that. Sorry. Okay. Let's get started. So we got 18 viewers. We got quite a few individuals that are probably just like may have been existing patients of ours, may be interested in potentially working with us. We want to really save time near the end of this to just answer a shit ton of questions. So let's just kind of get into it right now. One thing I want to start with is like, look, a lot of you guys that are here may have already, if you've been dealing with pain in any of the pain pattern regions here, have gone to your primary care, have gone to an orthopedic surgeon, have gone to a specialist, and may have been given a diagnosis, right? And so I'm actually a bit curious of what sort of diagnosis were you provided at the end of your specific episode with your primary care physician. And then once you guys sort of drop those in the chat, I want you guys to try to answer this question. What do you guys think is the number one diagnosis that is actually associated with wrist pain at the very moment? And so, we'll think we got swollen for a weekend, thumb was extremely swollen, blah, blah, blah. Yeah. 1 month into no video games. Yeah, we're definitely going to be able to help answer a lot of these things. When you can get started, why you can get started earlier, a lot of P7, P8s. Oh, wait, no. Okay, a lot of P7, P8s, right? So P7s, yeah, thumb, thenar. 1 year, okay, despite PT. How common is complete recovery? It's very common if it's treated well. My physio said forearms are too weak, needed strengthening, and gave classic reps. Okay, that's pretty par for the
10
course.
rep classic.
Yeah, right. The general shotgun based approach. Now, the reason why I ask this is because most of the time when we go through these free consultations with our clients, what I get, and you guys can kind of share sort of the discussions you guys have had, it's either tendonitis, it's either carpal tunnel, it's literally, I don't know, let's send them to orthopedic surgeon who also just might say, yeah, it's tendonitis, but doesn't tell them what tendon. So what actually is one of the most common diagnoses is it's not carpal tunnel syndrome, even though I think if you're here, you may already be aware of sort of the narrative or concept or idea that carpal tunnel syndrome may be often not misdiagnosed, but more diagnosed with limited understanding of the comprehensive clinical picture of what the individual is dealing with. And it's sort of a fallback diagnosis. So actually, it is a misdiagnosis, right? So maybe like that's probably the best way to describe it. And it's not carpal tunnel syndrome, but most often the active tissues of our wrist and hands that we use so commonly that are influenced by and then are represented by all these patterns. So every one of these patterns typically has a set or a specific muscle and tendon that we use on a regular basis, whether we're drawing, holding a mouse, you know, playing your violin, the bow side, the string side, the bow side, the fret hand for a guitar player, the pick hand or finger picking for the right side if you're a left-handed player or right-handed player. And so what we're doing on a regular basis influences what muscles and tendons we use. And those are the tendons that are typically involved. Now, the reason why I wanted to start with this topic that I wanted to talk about, which was more, hey, how do you actually get a good diagnosis? Or how do you know if the diagnosis is accurate or not? And before I get into that and sort of the 3 topics that we're going to cover, I want to let you guys know how this is going to work. We're going to cover these basic topics. We'll leave room for Q&A, and we're going to try to get into as much depth as possible. And then hopefully we can make it a bit more engaging where you guys can ask questions, you guys can drop things in the chat. And then because we want you guys to critically think. We want you guys to even challenge some of the things that we might be presenting here because we can provide the context or maybe nuance of things that you may not have been told or may not have been considered as your case has been diagnosed or even interventions have been prescribed. Basically, like what have you been told and what do they tell you is going to help? So maybe you guys, before we kind of get into this, is like, what are the reasons why you guys are here? Drop in the chat, 1 through 5. What are the reasons why you guys came to this Q&A presentation today? 1, you have wrist pain, you want to learn more about it. 2, you've been to doctors that don't understand gaming or RSI or music production or violin, whatever, right? Drums. What are the unique tasks that you guys have seen, Elliot and Brett? Like more unique tasks.
Pickleball, I guess.
True, pickle.
Super common.
Yeah, pickleball. 3, yeah, right. You've started some stretches.
Rock climbing's always popular.
Rock climbing,
Yoga.
golfing.
No, let's get in there. Like, what are the unique ones? Knitting, crocheting, drawing, painting. Those are not out of the ordinary. Yeah. Anyways, whatever task, they don't understand it. So we got a lot of 1s and 3s. We got lots of 5s. Clearly, everyone loves me. Number 4, you have to get things changed, but you don't know how. Maybe 1, 2, 3, 1, 2, 3, 3, 3, 3. Okay. Yep. So good. Yep. Then you guys are clearly in the right place.
Crochet. Your physio laughed at you when you said crochet.
That's fucked up. That's fucked up. You know what? Tell me what their address is. Tell me what their address is. I'm leaving right now. I'm going.
Matt's got something to mail them.
Anyways, guys, I got my karambit. It's over. No,
You're gonna get it demonetized, Matt.
Oh no! No. Okay, guys, let's get started. What I wanted to talk to you guys today was why your doctor's visit, not only with your primary care doctor, but also potentially with your specialist, or why it is likely incomplete, right? And why it's actually not really possible to get a good comprehensive assessment within 10 to 15 minutes. Now, everyone in here, please answer this question. How long did your doctors spend with you? You can say primary care, 5 minutes, orthopedic specialist, 2 minutes, or primary care, 30 minutes. Specialist, 7 minutes, whatever. Drop that. I need to know because I want to, one, show you guys with our little small sample size of 20 n equals 22, but also share our own experience. Right, we got 15 minutes. Maybe that's primary care, maybe specialist, hand specialist, 15. Physio, 30 to 45.
Yeah.
Physios, we got time. Yeah, we definitely got time. Okay, now mine is the either holding a Kindle. Yep, specialized primary clinic, 30 minutes. That's pretty good. That's pretty good. Good. And then 3 minutes personal, and then 3 months. That's more what we see as sort of like not just in the US, but in certain areas. Actually, like the UK is notorious and for having real delays in accessing specialist care. So yeah, that's just like, I don't know why their healthcare system is the way they grade and they determine how like these specialist visits are approved. It's not as efficient as sort of like what we've seen. So clearly
they're good, they can be fast, or they can be cheap, and you get to pick two. So the UK, it's fast and it's cheap.
Right. So wow, awesome. So like it's kind of a pretty wide range, and I would say like pretty awesome that you guys have had individuals that were able to spend an hour with you. I love that because at our minimum, we like to spend at least 90 minutes the first time. At least that's sort of our minimum during our free consultations. That's the time it takes for us to understand the big picture. Now, if I asked you guys a follow-up, do you think that what they did was enough to get a comprehensive diagnosis? And did they have enough time to educate you or teach you why what my diagnosis is, why I'm confident in that, and why what I'm asking you to do, rest, brace, ice, kinesio tape, passive interventions, injections, PRP, referral to specialists, why that will help you achieve long-term relief. And per usual, I never have the Jeopardy soundtrack, but I need some I need to make up my own. We got AI now, you know, that will allow us to create some pretty cool music. Got to come up with something. Okay, so
Jeopardy-esque.
Curious what they talked about. 30 to 40. Only spent 15 minutes with me, right? And so like, what do you guys think? Was it enough? Did they have enough time to teach you? And I would say like, as you guys are kind of thinking about it, it's really not enough. Now, it's possible, but these are some of the things that they should be inquiring about. They should really try to understand around your specific case. Within 30 minutes, let's say we give them the benefit of the doubt. Now, when they ask about things like medical history, they need to ask, you know, what did you try? What were you told? How was that diagnosis made? And how is the intervention? How is that told to you that takes into consideration of some of these other factors of how that's going to help you restore your ability to use your hands? How in depth did those providers educate you on what you're dealing with and why? Right? That's how we like to explore the medical history. We need to know what you were told. What did the orthopedic surgeon say? Why was he confident in saying that maybe surgery is the next step? And many times they're kind of straightforward. I can't do anything. You know, the best I can do is give you a surgery, and I don't even know if that works. Like I've heard that at least in the past week 20 times, right? That's what my orthopedic surgeon told me. Now, that's just the medical history. Maybe that's like 10, 15 minutes for us. We like to get into that clear clinical picture, which involves your work. What are the specific activities that you do? Typing, mouse use, gaming, phone use, crocheting, drawing. What pen are you using? What grip are you using? Now, if I break down your specific schedule, and I've talked about this in my content, I literally ask from the moment they wake up, when they're wake time, then what do you do? I drive to work or I work from home. I hop on the computer. I do exercise up until that time, from 9 to 12. Then in that window, what I do is I on average take like 1 to 2 breaks. Okay, now when they tell me 9 to 12 is their first work block, what I ask is, in that time, what is the percentage time of actively using your hands for any input device, right? It could be I use 50% right side mouse, 50% left mouse, 20% of the time I use a roller mouse, 10% of the time I use dictation. We need to know that, because what we're trying to build, and obviously that's super nuanced. We have more time to be able to get into to understanding that. But what we're trying to understand is, what is the load that is being applied on your body every second of the day, so we can have variables to modify. Okay? We need to know the variables that we can modify. Then we say, okay, when does your pain start? How bad is it? How does it behave? How long does it last for? What part of the movement? Because that tells us the severity, how irritable it is, and even the presence of potential sensitization if it's outsized pain response to a very low load. Then we ask ergonomics. What is your posture? Are you floating? What ergonomic station do you have? What keyboard? What mouse? Do you have binds? What ways do you help to be more efficient? How do you distribute it? What does your work understand about your situation? We need to know everything. And then we also look at your capacity, and we ask, did your previous providers do an endurance test? Did they do a strength test? Did they do a mobility test? Did they look at your nerve mobility? Did they ask about your physical activity when it first started versus what you're doing now? And did they help you understand that relationship between, if you don't have that much physical activity, how does that influence the conditioning or capacity of your body? We have to ask all of these things. 10 to 15 minutes is not enough. Now, an hour is. So shout out to the one physio that spent an hour. Let's go. But they might not have gotten down and have the ability to ask with the right approach to narrow down the data that's relevant, right? And it's hard. Clearly, it's hard because we're trying to actually help more providers learn what to ask, learn how to treat, learn how to educate, right? And so what we always like to ask is like, what tests did they perform? Did they ask about your lifestyle? Did they test your endurance? 99 times out of 10, they say no, they didn't. They didn't do any of that. They didn't teach me. They didn't help me understand what tissue. They said tendonitis, but they didn't say which tendon. They said imaging found nothing, and then they just let me go. That's not enough in the 15 minutes or 5 to 7 minutes, whatever, for specialists, right? Now, this is what we typically see actually happens, which is, okay, I look at your pain. How bad is it? We'll do some Phelan's tests, ask a questionnaire. Do you have numbness? And then they say, all right, got it. Must be carpal tunnel. And that's it. Truly, that is like the only depth that they get to. Now, to give some individuals credit, they actually recognize that they don't know. So they'll refer to a specialist, right? And now I wanted to highlight, why does this happen? You know, when you actually go to the specialist, the individual should be better, but they get even less time. And then there's no communication between the primary care and the orthopedic surgeon. And so how do you expect what they tell you to be considerate of what's actually going on? Now, I don't know if there's any doomers in here that came in from Reddit, but if you're here and you believe that you really believe what the orthopedic surgeon told you, I want to just ask you, do you feel confident in their diagnosis? Is their diagnosis comprehensive enough based on what you just heard that gives them the ability to say surgery is the only option, or you should quit your job, or you should think about doing something different? Both of those, they have limited to no information to be able to even remotely have any confidence in saying. Now, I want to also emphasize, like, it's their fault, but it's also not really their fault. And I'm not trying to protect them. It's just our systems, for the lack of a better word, it's fucked, right? Internationally, our healthcare system is fucked. And the number one reason is that it starts from education. Now, when I say education, I mean that our doctors are taught in a structured way, right? They're taught what they need to know. Now, when we actually assess how many individuals go to urgent care and primary care, there's like what we know is that roughly 30% of those visits represent some sort of musculoskeletal problem. Now, what do we see when we actually look into curriculum? Some studies for the schools in California showed less than 3% is devoted to understanding and treating musculoskeletal issues. And more than half of that 3% is just assessment and rehab, not actually understanding all the other ways of that we sort of discussed can be helpful in treating. Now, only 15% of medical schools, 15, require a rotation. That means they go send them to a hospital where they specialize in understanding how to treat musculoskeletal medication. And then in a 2024 review, this one's interesting, they found that when they tested recent grads, current practicing physicians, and generalized physicians that may be in academia, guess how so what they did was they put them through a test of 25 questions. It was a competency test. Guess how many of the recent grads passed? Drop it in the chat. What do you guys think? What's the percentage of individuals that passed? I can drop the references at the very end of this. It's real. 25 questions. Are you competent in treating? What do we have? What are the notes? 8%, 30%. All right. Okay, so for recent grads, 79% failed. Okay? 21% of physicians passed. Now, residents and staff physicians, practicing physicians, 50% failed. So you guys want to trust these diagnoses? Again, it's not their fault because have they been taught appropriately? No. Now, the reason why they don't have incentives is because the healthcare system doesn't give them time. And think about who these primary care and urgent care physicians see all the time. Do they care about repetitive strain injuries when they're seeing heart problems, liver problems, someone gets hit by a car, any of the conditions in PIT, right? If you watch that amazing show, right? And then you go to the primary care environment, blood pressure, diabetes, cancer management, underlying medical condition, chronic management. So they see maybe, again, the 30%, but the majority of their day is spent treating all these other issues. What do you think happens to their competency in treatment? Of course, it's going to be that 50%. It's not their fault because what would they rather treat? The thing that pays more money or the thing that doesn't pay them money, which is these musculoskeletal issues. Now, I don't have to get into all the billing stuff. I'm going to create I'm in the process of researching and writing an article because of all the discourse right now about AMA and the CPT and them getting sued because they have a monopoly on all the codes. It's actually really fascinating to learn about that. But the system's fucked, right? And then the third part of it is like, okay, well, when they refer to a specialist, they're supposed to know, but they only have 5 minutes. Again, not enough time. 2, they only are specialized in a small slice, right, of expertise. I only know nerves. I only assess nerves. There's nothing wrong with your nerves. So get out of here. Go see the orthopedic surgeon guy. Okay, let me do an MRI to your tendons. Let me do an ultrasound to look at your tendons. It's normal. I don't know why you're dealing with this. I didn't assess your endurance. Go see the physical therapist. And the physical therapist operates in a mill. Shout out to the 1 hour guy. Let's go, right? That guy is awesome. It's not normal. Shout out to that guy because he has time. And again, they will have to be able to do this comprehensive assessment to be able to say, this is what we found. This is your mobility. This is your endurance. This is how your pain is behaving. This is your understanding of pain. We take all of that. Now we understand how you're spending every second of the day. And let me help you understand. 1, where you need to be versus where you are now. When you reach this level of endurance, you should be able to handle 8 hours of work. When you reach this level of endurance, you should be able to handle 8 hours of work plus 1 to 3 hours of any hobby. That is actually what should happen on visit 1. That's what we like to help individuals understand at the end of our free consultation. Okay? And so when healthcare is fragmented, it doesn't give clarity again about what they're dealing with because they don't take into account the bigger picture. So I want to obviously review like, hey, you already saw what a good evaluation looks like given what I mentioned. But the plan is you establish the base. Where are you now? And where are you now with everything? With your lifestyle, your symptoms, what you understand about pain, your capacity. Then we work to address those things. And everyone's pie chart is a little different. And you have to do that through an understanding of pain. Because if you don't understand why, if you do exercises, you feel sharpness, and the sharpness actually goes away, and you can still use your hands, and that means you can still do your exercise and still do your activity. Or you feel sharpness and it lasts several hours, but it does go away. And again, you can still use your hands and you can still exercise in those moments and that you're safe. If you don't understand these scenarios and why you can be safe continuing despite sharpness, imagine how difficult it is to make progress. And that's obviously step 4, which is like we help you, a good evaluation teaches you one, where you're at so we can navigate that progression or graded exposure. Now that was the end of mine. Elliot will get into his, but before I go on, I just yapped for, I don't know, 30-20 minutes. Question?
Yeah, you said put together 3 to 5 minutes worth of content for this, and now you're gonna make us all look like slackers.
Yeah, well, I'm the founder. I have to go extra hard. So guys, questions about this first and foremost, and then we're gonna get into Elliot's and Brett's discussions, which are expectedly shorter because I went too hard. I'm sorry.
Overachiever over here.
Yeah, I'm Asian, so that's why. Asian, not Bayesian. I can say that.
You can. You're
So,
allowed.
I'm allowed. Don't call me Asian. Just kidding. All right. You guys didn't come here for the accents. What are the questions? If no questions, let's keep it going.
All right. So yeah, the next question we're going to answer that we get all the time is, can voice dictation reduce typing strain effectively? How many of you out there are actually using voice dictation? I want to see in the chat. Maybe you're a software engineer, something along those lines, and you're allocating some percentage of your day to voice dictation, or maybe you're allocating even more than that, like your whole day to it, which we see all the time. So the answer to this question is yes. Okay, I use voice dictation all the time, not for work. I'm an artist. Okay, typing to friends on Discord. Okay. Yeah, that makes a lot of sense. Would be hard to dictate drawing, I imagine, but would be cool.
Yo, that'd be sick. That'd be sick. Okay.
Maybe 10%, but not useful for spreadsheets now. Yeah. Tried a long time and it was too frustrating. Yeah, it sucks. It's a pain in the ass to use. So I'm assuming most people don't want to be using voice dictation. I have met some people that love it. They want to be Tony Stark talking to Jarvis all day, but most people really don't like voice dictation. But to answer the question, can it be an effective tool for combating a repetitive strain injury? Yes. But there's some really important nuance that we need to discuss here before we fully answer this question. So I want to get into like the 2 types of endurance that you have. So quick crash course on endurance. You have muscle fibers in your muscles that contract, that pull on the tendons, and the tendons pull on the bone. And those muscle fibers are responsible for high reps at low weight. And this is representative of your endurance capacity. How many times you can make these contractions, these small weight contractions, many times throughout the day. And when you're typing, it can be 10,000 plus contractions that are happening throughout the course of the day as you're doing these different repeated tasks on the computer. But there's two major categories of endurance that we like to break this up into. So we have general endurance on one side there, and that is how much muscle capacity these specific muscle groups have. So we're talking about your wrist flexors here, the flexor muscles in the forearm that are responsible for curling the fingers and the wrist down this way, the extensors that go the opposite direction and pull your fingers backwards like that, and then ulnar deviators, radial deviators, and then everything else that does all the intrinsic movements in your hands. All of these are controlled by specific muscle groups. There's clusters of muscles that are responsible for these movements, and they have general endurance. So we quantify that general endurance as the amount that you can do specific to your body weight for high reps. And I won't get too much into the nuance of how we exactly categorize that right now, because it really doesn't matter for this conversation. But general endurance is you're kind of like, think about it like more like your gym workout. And the way that we build and quantify general endurance is with the dumbbell. So we want to standardize the weight, we want to standardize the reps, and we want to know how much that muscle group can effectively do under a light load relative to your body weight. Specific endurance, on the other hand, is very, like it says, specific to the activity. When you're using the mouse, you're not just using your flexors. If you were just using your flexors, you would just be like flopping down through your desk. There'd be no control of the mouse. It would just be one muscle group going in one direction. In order to do a coordinated movement like typing and using the mouse, you need to use all of the muscles from your elbow all the way to your tips of your fingers in a coordinated way in order to do that specific activity. So specific endurance is how much endurance you have relative to these activities. And this is different than general endurance because this is very much a use it or lose it type of situation. I think you can switch to the next slide there.
Use
That's big
it
and highlighted.
or lose
Use
it.
it or lose it. So specific endurance, it's really important that if you want to continue doing an activity, even if you're in the recovery process, you continue to do that activity to some degree in order to go through a process that we call graded exposure. And it's not just we calling it, this is established in the research. The process of graded exposure, where you're continuing to use a muscle group for a specific activity over and over and over again. So you continue building up and building up and building up. And that's the foundation of the rehab process. So assuming your goal is not to stay voice dictating everything forever, we want to know how much you should use this muscle group, these muscle groups for these specific activities, without going into the upper limit that you can see on this chart here, or too little so that you're in that lower limit. And this is called the envelope of function in the literature, but we call it the Goldilocks zone. It's not too much, it's not too little, it's just right. And this is different for everybody, depending on where your capacity is currently, how much you can do before pain sets in. We ask a lot of questions during our evaluation process to determine kind of where people are with this. We want to know what the pain is at rest. We want to know how bad is it when it flares up. We want to know how long it takes for it to become irritable. We want to know how long it takes for that pain to dissipate once it is irritable. We use all of that to determine where on this envelope of function is the right amount to use your hands for a specific activity, so that you're not putting into that physiological area of strain up there, and you're not doing too little to where the muscles are just atrophying and you're losing function over time. Let's go ahead and swap. So the way I want you guys to think about voice dictation is not just this on-off switch. It's like, okay, I'm just going to stop typing for multiple weeks on end. I'm just going to use voice dictation, because that's going to do what's called stress shielding. When you shield your tissues from stress, it feels better. I get that. It feels great. You're not using them. But at the same time, you're also losing that capacity, which ultimately makes it worse when you try to come back to activity. So the trap here is to completely stop using your hands for all typing activity and just relying on this voice dictation. What we want to do is we want to think about voice dictation like a dial here that we can turn up and we can turn down. And this can be done on a day-to-day kind of basis, depending on other factors that are going on in your life, how much pain, irritability you have, that irritability index that we calculate out for you based on a lot of those factors to know where you are in that Goldilocks zone. But we can dial it up or we can dial it down depending on that irritability. And this is ultimately how we continue using your muscles and those tissues for these functional activities like typing without overloading them and giving you enough enough strain, honestly, in order for it to continue building the properties of muscles that you need in order to eventually handle that 8 to 10 hour workday. So let's go ahead and switch to the next slide here. So what this looks like is you want to know kind of where you are in that envelope of function. How much time before the symptoms become too symptomatic to where you can have a good frame of reference for this is about how much I should use my hands before you can think about voice dictation like taking a break, before taking a break from using your hands and typing. And the amount of time that you take a break depends on how long it takes for those symptoms to subside by a certain percentage of what they were before. Then you would go back to typing. And then as you go throughout the day, you're kind of losing more and more capacity. You're not fully recovering it. So this can look shorter and shorter and shorter windows throughout the day. But the point is we want to have a certain percentage of time that we are actually using our hands for the functional task as much as we can tolerate. And this is where we get into much more nuance when we're working with people. We help them understand exactly where these limits are. But just speaking generally, this is the strategy that we take when someone is using voice dictation, or sometimes we'll even recommend using voice dictation for someone that has very high irritability and needs to make it through their workday, and they really have no other choice than to do their high performance job. So I hope that sheds some light on this. I wanted to open up the floor if there's any questions about kind of what we just talked about. No questions for me.
Yeah,
that means I did a
basically,
good job of explaining it.
yeah, basically, the TLDR is what? It has a role, but we're trying to build up your capacity so that you don't have to rely on it. Some people, they find that, you know, using Whisper for a specific subset of tasks can be beneficial in terms of it feeling more efficient. And so we don't force them to change, which is all our goal is what do you want to be able to do on a regular basis? I want to be able to handle 8 hours, and then I want to play 3 hours of games, and then I want to go to the gym. Well, let's get your body prepared to handle that. That's basically how we work. And then we have to ask about pain, help you understand what you feel, why you feel it. Do you know how to better think about this reason? Are you able to attribute why you're feeling pain? And that's probably what we're going to cover in a lot of the Q&A. But yes, wow. So he says braces, almost same person taking over braces. And guess what? That's our next topic.
That'll be a great segue.
What a great segue. I love
Thanks.
2 wheels and a handle.
And we have our little Confederate in the chat. Thanks, Tabraham.
Thank you for that setup.
I don't know. Is that what they're called? Confederate? Anyways, go on.
What are you talking about?
I don't know, man. That's just the verbiage that I remember. You know, that they're part of the study, right? Is that what are they called?
Cohort?
No. They're part of the study, but they're the study designers, and they're there to influence the group in a certain way. Group A versus Group B.
Okay. So we're not talking about the guys with the lifted trucks and the stars.
It's a Confederate, dude. I'm telling you.
Okay,
I'm fucking telling you guys. Real participants think the Confederate is just another subject or bystander, okay? But they follow specific instructions to create controlled social situation. Don't fucking try to scam me! Alright, go ahead. Thank you, C. Martin.
I learned something today.
Alright, go ahead. Sorry, guys. I really wanted to...
Right.
It is Confederate. I'm not... I know this.
I understand what he meant.
Thanks, guys.
So yes, good segue into me talking about bracing, splints, gloves, wrist support, anything like that. So just a little background about me. Just not too long ago, I was working in the clinic and I would get the patients referred to me all the time. The doctor would say, okay, they need a brace, fix them up a brace. And, there might be situations where a brace is helpful. Maybe in chat, you could list out a few. When would a brace be necessary?
Oh, good. By the way, guys, Brett is a occupational therapist, if you didn't know, and he's a pain science specialist. Let me just quickly hit him with this. So you guys have our labels here. This is who we are. Yes. Okay, there we go. Now that that's established, we have quite. Is there a reason such a disparity in PT training on RSI? Really good question. Yeah, I want to emphasize while we wait for the examples, like we understand that physicians don't have time. It's their fault and it's not their fault at the same time. They just don't have the incentives to be better at their job because they're just going there for one, for a paycheck, but two, they don't see these types of conditions enough to warrant, let me take an educational course to learn. It is their job, but they don't operate in a system that supports it. Nighttime to prevent re-injury. What is it, Brad?
Sure. So, I mean, broken bones, right? You have a fracture. That would probably be an important time to immobilize something, right? After post-op, that would be a good time. We don't want to ruin what surgery we just had. Flexor tendons, extensor tendon lacerations, those might be important times. But RSI, that might not be the crucial time to always brace. There may be some outlying situations, like nighttime, right? That could be a time that we look at.
Sorry.
But yeah, again, we have to know that support is simply just a tool, right? It's not the treatment. So what does a brace do ultimately? A brace prevents movement. That's the main premise of it. And by bracing and preventing movement, we make up for that lost movement elsewhere. So that means maybe we're going to be more reliant on our fingers, potentially on our elbow, on our shoulder. We're going to move in different ways in order to get the job done. Now with this, there are ways that we can modify activities. And so modification is changing how you're doing something. And we can either make it harder or make it easier for us. And that's the thing that we would want to play with a little bit more. So we should first modify the task. And then if we're unable to tolerate that, right, if we have to do that, then we could look at bracing if absolutely necessary. But we have to remember that we should brace as little as possible. The end goal is to build up our endurance, our tolerance back. So we need to be mindful of that. And we have to take off the brace several times. So even if it would be a post-op patient, I would have them take off the brace, get moving, as much as they were allowed to at that time. For RSI, again, we want to be mindful of how much we're bracing and not become reliant on it.
Small little note on post-op bracing. Think about incentives for orthopedic surgeons and why post-op recommendations are pretty conservative. Do they want to be associated with a failed surgery? And if not, then how would they protect their surgery? By being overly protective in getting you to move so the pain goes down, but they don't ever okay, well, the occupational therapist and physical therapist, they're responsible for the rehab. Now, that's wherein the dynamic between the physical therapist and the orthopedic surgeon is really necessary. Me, all day, I'm fighting them like, hey, I'm getting them started day one. Sorry, bro. I'm not going to wait the 7 weeks that you said to get out of the splint. Obviously, it depends on the actual surgery, what they did, but most often what we're seeing the research trend toward is earlier and accelerated mobility leads to better and faster functional outcomes with the same amount of pain. Anyways, just wanted to add that.
Yeah, that's a good point. I mean, right, you can form relationships in healthcare where if I'd be close with a hand surgeon who really trusted me, they saw good rehab progress, they would trust my decision making and kind of let me lead there. So there were times where you could kind of wean them out of the brace a little bit earlier than they previously mentioned, but there are certain surgeons that will really latch on to immobilize for an extended period of time that ultimately can be more detrimental by doing so. Again, as Elliot mentioned, prior to that, there is that stress shielding. We need to expose this, we need to expose our body to an amount of stress as long as it's within that Goldilocks range. Without doing so, we can obviously decrease that health bar, which we want to avoid. Ultimately, we want to increase that size of the health bar because that's going to give us the more capacity to complete what we want to complete, right? We're losing that endurance every time we put that brace back on and wear it for prolonged periods of time. So there's some good evidence to say after 3 weeks in wearing a brace, right, we might lose 30% of that strength. 45% of our endurance is lost after 3 weeks in the brace. So we do want to work out of that as fast as we possibly can.
And you would think, right, like with this being published, this is out there. You can just
The
imagine.
crazy stat.
Isn't that crazy that doctors, because they are not aware of this, they'd be like, just rest 6 weeks, come back, let me know if it's better. What do you expect?
Most doctors' philosophy is to just try to hit the reset button. And this is oftentimes why surgery gets prescribed as well. They know if they stick you in a brace or if they cut you open, then you're going to have to be in a brace and you're going to have like this big, massive nuclear reset that happens where then you're going to have to go to occupational therapy and you're going to have to start from square one and you're going to have to start building up. And they're just hoping along the lines that you gradually expose things correctly and then you're eventually able to get back to 100%. Like, it's the nuclear option for just hitting that big reset button a lot of times I've found.
Yep.
And sometimes it works. Like, it takes forever and there's all kinds of complications that arise, but sometimes it does work, especially if you're not trying to get back to a super demanding task. But by and large, a lot of times people will have done the surgery and then they'll do the bracing and then they'll be like, and then they go through the therapy and it's not enough to get them back because the exposure schedule wasn't, for lack of a better term, aggressive enough to get them back to the high performance activity that caused this in the first place. They just end up right in the same position as they were before.
Yeah, most of the time, the rehab, they just don't understand how important it is to build up the capacity. And so what they're focused on is, oh, the pain is gone. And all the doctors ask is like, how's your pain? How's your pain? How's your pain? Well, what about function? Like, well, what about like if I want to do more than my typing? You just ask, right? Like, they'll be like, just wait, you'll get better. Like that's most of the time their response instead of, well, we know that this specific activity, because it's higher and more dynamic and load, it requires this specific amount of endurance and this specific amount of plyometric capacity. Now we have to get you to that point, and once we get you to that point, we have to show you in small increments that this is safe. And then once you show you that this is safe, then we'll sort of clear you to more fully be able to do it. Yeah. Any orthopedic surgeons here did that with you, or any physical therapists did that with you? I would bet $1 million. None of them did. I would literally bet $1 million that none of them went through that exact process to show you why you can safely get back to doing exactly what you want to do for your amount of time and how to feel safe when you're feeling your symptoms. I can literally bet my entire life that they will not have done that. And that's why the outcomes are the outcomes. How do you expect to get better? Sorry, we kind of took over this part of the discussion, Brett, but
no, you're good.
So you can continue.
So, I mean, exactly. I mean, pain, yes, that can subside with bracing at times, but do we really think that's going to improve our function? And now getting back into our activities, you might have to even fight people to remove the brace because the next thing they do, they're going to want, to put that brace back on because they felt a 1, 2, 3 out of 10 pain. We have to challenge that. We have to find that that's in the Goldilocks zone. And truly that is a safe amount of discomfort for us to expose ourselves to. So it's that weaning process. Weaning means I'm just going to gradually wear it less and less and less over a period of time to introduce, right, more activity. And we can do it in a graded and gradual way, that highlights safety. If you've been wearing it all the time for a year, and we have you just jump into rock climbing, that might be too aggressive. That might be too much. But there is a way out of bracing, and it's starting gradually and working your way up from there. Beyond that, we know that it's important to build up those tendons, right? They've atrophied. And so we have to give it load. We have to give it the stimulus in order to repair, right? So that's when the exercises are crucial. And so we can take off the braces because by doing exercises, that's a very controlled method for us to load these. So we can do, wrist curls, right? Wrist extension. We can do some grip training. Those things are safe because we can control every single variable about those.
Yeah, and I think like because so many people have had poor experiences around physical therapy, they think that it's just 3 sets of 10 full range of motion. Actually, there's like millions of ways to progress, regress. You can do first set, you do higher load. Second 2 sets, you do less. You can do partial range of motion. You can modify the grip. You can do different types of weights. You can do very grip. You can do tennis ball. You can do a cup. You can do rubber bands. You can do a key pinch grip for the thumb side. There's literally millions of ways to progress and regress. But what the traditional physical therapists and occupational therapists only know is, I know thumb pain. I do this. It no help. I know why. That's usually the response, right? And so it's like, well, I did the 3 sets of 10. Well, what we learned is we have to have a sniper when it comes to prescribing instead of a shotgun. And when I say sniper, I mean, look, I showed you during day 1, you were able to do 45 reps, which means I can probably distribute that in 3 sets of 15. So I'm going to choose 15. Or when you did 45, you led to more overall soreness. I don't want to get to that level of irritability. So I'm going to choose 12 and I'll ask you to rest a little bit longer between sets. Do you see how much more specific the prescription of exercise can influence how you feel and how safe you feel during the exercise? I hope you guys can see that. And then I think as a last thing, like I really like this slide because it's like you can modify the tasks, right? So maybe you can describe that, but yeah.
Yeah, so exactly. I mean, right, we can definitely find a way to modify something that we absolutely have to do, right? So if we have to do something, then sure, maybe we can continue it and then use the brace as, as the last 5 minutes potentially. But yeah, I mean, we really just have to find, okay, there's ways to grade it up or grade it down, and find what's most challenging and what we can handle at that moment. So there's definitely different routes that we can take along that decision making.
Yeah. And this is sort of like a quick way to review how, hey, like if I can modify it, if my work allows, then I will. I'll use dictation or I'll use a vertical mouse. If I have to do this task, well, I actually need to understand what is actually considered a real flare up. What's too much? What's too little? If it is something that's flaring me up, then I actually have to somehow make a modification that limits the me actually reaching strain. And I'm going to tell you guys right now, 99% of what you guys define as a flare up is not a flare up. I'll actually define it for you once we get into the questions because we're probably going to get into that. But that basically is it, right? More restriction or bracing doesn't mean more recovery. Now, let's take this next hour to go through questions. But maybe you guys can, before we get to that, like, what did you guys learn? What was something you guys learned that is maybe already helping you understand things differently? And then right after that, drop all your questions immediately and we're going to go through them. And let me see if I can start. I'll load up my little paint, because I love to draw. Oh, actually, no. I'm not going to load up paint. I'll load up visible body. Visible body, baby. Because our bodies should be visible. Okay. Visible body suite. Okay, here we go. Boom. Now, let me just... Oh, it's working. It's already swapped. Wow. That's nice.
I need to step away for a minute. I'll be right back.
Okay. Let's see. can you guys see this text on the screen if I draw it? Let me see. Oh, actually. Oh, it's paused. Oops. Share. Presenter. Uh-oh. Presenter window. No. What happened to my screen? Oh, I accidentally exited out. Can you still see my screen? Brett? Yeah, right?
Yes. Yep. Yep.
Okay,
Yep.
okay, perfect. Okay. Then what I want to ask is, oh man, where's my drawing? Oh, I see. There we go. But once I do this, can you guys see this drawing? Can I? Oh, perfect. It's working, right? You guys can see that? Okay, so this will be the question. Okay. Doctors, I'm seeing a full of crap. Resting is going to help. Good. Great info. Thank you. Helpful. I don't want doctors. Don't have centers. Blah, blah, blah. What can I do for my thumb? Hobo. Hobozo. All right. We got Hobozo. Hobozo says.
I don't know if they're.
What?
I don't know if they're able to see it on the stream.
Oh, okay. What can I do for my thumb if it feels stiff and dry? And loses strength after a few hours of gaming. Guys, let me know in the chat if you guys can see this of gaming. It gets inflamed, and my brain just forced me into popping the joint so it gets some relief. Let me know, guys. Can you see this? Yes or no? I can't see the text. Okay, well, then I'm just a problem. Okay. Can't see anything. No problem. Well, I will then do this. I've read it, and yeah, Brett, maybe you can answer while I figure out this thing. So the question is, what can I do for my thumb if it feels stiff and dry and loses strength after a few hours of gaming? It gets inflamed, and my brain just forced me into popping the joint so it gets some relief.
So it looks like the next comment, I took it to the doctor. One of them told me to brace, but the other one said don't. So I'm confused. Yeah, I mean, that's the unfortunate thing with, you know, these different doctors and hearing both multiple answers. You know, when I hear that stiffness, you know, loss of strength with a few hours of gaming, you know, naturally I would say, okay, we need to build up some endurance somewhere. So, you know, if it's your thumb, we would think, okay, is it going to be our flexor or our extensor side of the thumb, first of all. So you can really go through some of these pain regions and notice, like, am I feeling it more on the front side? Maybe I want to work more on thumb flexion, right? Maybe doing some pinches right here. Maybe some grip strengthening, right? Some rubber band work.
Oh yeah, my bad, guys. This is.
Or maybe I want to work on. There we go.
Sorry, guys. It's
work on some thumb extension as well. You know, it really depends on where you're feeling that stiffness or that loss of strength. It would be helpful to know, you know, what games that you're feeling it while playing. Yep, that's on the flexion side. You know, is it mouse and keyboard? Is it controller? So if it's on that flexion side, right, I would really look to build up the flexor side of the thumb. You know, stretches can be useful as well. I tried doing exercise with it, but it made it feel more inflamed sometimes. Better, sometimes worse. Okay. On the mouse. Okay. Extension as well. Sure. How long were you doing some exercises for this? And when you did brace, how long did you brace for, and did that seem helpful at all? Max. Okay. So a week, I would really see if we can find that range where we work it a little bit more. I braced it for 2 weeks, but on and off kind of, and felt like it developed wrist issues because of the brace. So they might have had you in a forearm based thumb spica. It would be my guess, right? So it'd be something that would include the wrist and it would go along here. Did they mention a diagnosis that they were thinking? Did they say deeper veins? I'm sure at that moment they ruled out any fracture, did some imaging potentially. And it sounds like they gave no exercises in that moment.
I would say, like, it sounds like what we would need to do, obviously doing through a Q&A, we're not going to be able to assess, but we would want to know where your capacity is, right? And our test is typically, based on the muscle group or muscle region. You do a certain amount of reps with your percentage body weight, and you need to have a certain amount. Set a baseline. We need to know what that is. And then 2, the other part is like, look, we need to also teach you more about pain. And, that really comes down to like, this question here: define a flare up. And how do you understand how many days of pain is okay after activity? Are you guys ready to understand what a flare up actually is? Okay. This is what we consider to be a true strain of your tissue. Okay. If you feel greater than 5 to 6 out of 10, it's sharp. It's sharp every time. It's so sharp that every single time you move your wrist and hand, you will feel that level of sharpness. Now, it's not only that, right? Every time you move it, sharp, sharp, sharp. It could be even 7, 8. But at the same time, if you go and try to pick up a cup of water, you'll want to drop it because you'll feel associated weakness and sharpness. And that will be consistent. Every single time you try to use it, it will feel weak and sharp. Not weak, like that, weak and sharp. Basically, you are unable to use it for the rest of the day. That will last the rest of the day. This will last until the next day. And the next day, it will be at 3 to 4 out of 10. But it will also be sharp every single time. And there will also be weakness. And you will also be limited in your ability to use it. Now, if you have not reached this point, then it's our job to work with you as the healthcare provider to determine what is actually contributing to your elevated symptoms. And that requires us to sit down and be like, okay, well, what did you do yesterday? Was it a combination of your exercise and your activity and your work, and you decided to go bowling, and you decided to go rock climbing, and then you decided to fire spin? I don't know. We had to figure out what led to increased load. And if you did 30 minutes more than your average, or 1 hour more than your average, or the binds that you use only use your thumb, then you would expect elevated symptoms. Now, the elevated symptoms, if it doesn't reach strain, again, we can be confident that you actually haven't damaged anything. However, you may have irritated it, or there's the idea or concept of sensitization. And I'm not going to go into full depth about or details about it, but the idea is like, look, based on our past experiences, based on the things that we've experienced and exposed and our understanding of pain, if we think pain means damage, it can make our pain feel worse. And it can even make you feel 7 to 8 out of 10, but then the pain goes away and then you try exercise and it feels totally fine. Sensitization and the cognitive emotional aspect can lead to you feeling more pain. So if I'm answering this question as well as like further answering the Hobozo question, the diagnosis may or may not be true. It likely involves the same muscles and tendons that we were trying to explore. We have to build up the capacity by having you do exercises. If a certain amount of exercise is leading to close to strain or less than strain under what I just defined it as, then let me see if I can bring it back. Under this, then we can either continue the exercises or we can find the modification, because I don't want you to deal with pain. So let's say you do 3 sets of 12 and it led to this feeling. Then I would say, okay, well, let's do 3 sets of 8 to 10 and rest a little bit more in between. And also at the same time, reduce your gaming, right? And so how many days of pain is okay after activity. Unfortunately, there's not just a, hey, it's this. It has to be 3, because some people, due to how long they've been dealing with pain, can feel pain for several weeks, 2 to 3 out of 10, but they're safe and they can keep doing exercises every day, up to twice a day, up to 120 reps or 180 reps every single day for their wrist and hand. It sounds like a lot, but that's sometimes for certain individuals the volume that you would need to build up capacity. Now, again, there's no solid answer for this because the amount of days of pain is influenced by all the other variables that I just told you, right? That I was just mentioning, which is like, oh, if I drew a pie chart and you're really weak and you barely exercise and you're really sensitive, then we got to treat the sensitivity. We got to treat your understanding of pain. We got to help you feel safe, or we got to get you moving more. Or for someone else, it might be like, yo, I can barely lift 1 pound, so the P is here and the M is here and the lifestyle is here. Everyone's different. Now, let's get to, hopefully that helps give clarity around what's okay versus not okay, C. Martin. But often, if it doesn't reach strain, you can still do exercises. You have to make some modifications to affect how you feel, but you have to learn about pain. You have to know that you're safe. You have to know why you're safe, because it hasn't reached strain. And you have to know how your past experiences are influencing and leading to more signaling that causes your brain to feel dangerous or in danger or overprotective. Now let's get to this one. I have wrist tendonitis. Maybe Elliot, you can answer this. I recently hit the ulnar side of the back of my hand, just below the base of my little finger. Okay, let's say back side of my hand, just below the base of my little finger. Okay, right here maybe. It doesn't hurt when I press on it, but when it hurts when I make a fist or grip something tightly. Doing resistance exercises. All right, this is a super easy one. So layup.
Yeah, so when you have tendonitis, the area is irritated, right? And there's a process that the nervous system goes through when you have an area that consistently gets irritated. Repetitive strain injuries never happen overnight, right? Like you didn't like this when you hit your hand, that wasn't the source of the RSI that you already have. And repetitive strain injury never comes from, falling on an outstretched hand and like spraining your wrist. Like that's not a repetitive strain injury by nature. That is a injury, an acute injury. So repetitive strain injuries are always occurring over this kind of prolonged period of time, where eventually there's a point where there's like usually a straw that breaks the camel's back and you start to notice that injury. When that injury has been going on for so long, there's a certain amount of nervous system sensitization that takes place throughout that entire process. You have these nerve endings that are called nociceptors, and nociceptors are responsible for sending danger signals to the brain. A lot of people think about these as pain receptors, but they're not really pain receptors. They sense danger. And the way that they sense danger is they sense mechanical inputs in very high volumes. So these nociceptors are designed to detect high pressure changes, high chemical changes, and those are often the two that trigger these nociceptors to do what's called upregulate, or they do their job better the more that they get triggered. So having a repetitive strain injury already means that you have a reactive nervous system above and beyond kind of what would be the normal threshold. So when you do something like introduce a physical impact to that area, it's going to be more sensitive just by nature of the already sensitized area that is there because of the chronic tendonitis that's been going on. So it's normal for minor injuries to feel and last longer when you have a tendinopathy like this, because that nervous system is more sensitive. And the whole process of addressing the root cause of that tendinopathy, that endurance deficit that caused this in the first place, is what helps to desensitize those nociceptors, restore their threshold back to the appropriate level of firing, so that they're no longer getting hyper triggered by all these like minor insults to the area like you see in this example here.
All right, perfect. Pain, Lin Chen says, pain in my web space between my thumb and index finger. Okay, let me just like, we got anatomy here. Let's show them what's good. Let's show them what's good. So between the thumb and index finger, if it's on the back side, And most of the time, what we see is it involves the muscle and tendon that's involved in bending your thumb closer together, the adductor, or bending your thumb towards the pinky. No pain when gaming or typing, but pain when I grip something. I play basketball, game, and work out. Should I do exercises even if it causes pain? Brett, what do you think?
So yes, I mean, I would say definitely that would be a good thing to introduce some exercises, and then right, finding what your tolerance level is and seeing if we can progress that up. So again, finding that Goldilocks zone. What can we do? What can we grip, right? And actively working on gripping. It doesn't have to be 100% effort. It could be 50% effort, right? And kind of making sure that thumb is involved. Yes, and maybe using a Varigrip right there to help with the thumb. So something to get that thumb involved. And then knowing that there's going to be some discomfort, but you can control it, right? So controlled discomfort on a frequent basis, and then you scale this up. You either scale up the resistance, the reps, the intensity behind it. And that would be the best way to gradually expose yourself so that you can tolerate, gripping harder things, gaming, working out, all the things that you want to be doing with less pain. So it is exposing yourself to pain purposefully. But again, also knowing that you're not doing any damage by doing that.
Wait, is there a double text on my screen, guys? Or what are we looking at?
No, on
right?
the video it looks
Nope.
okay.
Okay, good. Okay, now just to add to that, basically, I'm going to ask you, Lin Chen, would you expect if you started to do more exercise for the thumb that you'd be able to, when you play basketball, when you work out, would that, because that cause more soreness during those things? If you're passing, if you're doing some bounce pass, if you kind of shoot and you're the shooter type that kind of rolls their thumb out, that was me. I had to change it. Or when you're working out doing a grip related pull movement, right? Would you expect more soreness or pain there? Yes. Okay, I'm going to answer for you. Yes, you would expect more. And that's where it's important. You can choose to do the exercise, understanding in the short term, I'll do a little bit less of the things that I know are super high low that influence my thumb, the thumb muscle, because I'm training it. Now, it takes time, right? Nervous system adaptations, 2 to 3 weeks. Muscles, 6 weeks. Tendons, up to 8 weeks. Doesn't mean only after 8 weeks you're going to feel better. But it means that I got to be doing it for a consistent amount of time to ensure that I can handle more with whatever I'm doing. With basketball, working out, doing a pull movement, doing a clean, catching it, whatever, however you want to do it. Okay, now let's go to Valfreya and the harp. I said that perfectly, for sure. For endurance work, once the amount of sets and reps is well tolerated, do you typically recommend doing the 3 sets once a day, every 20 or twice a day? Amazing question. Now, what we found to lead to the fastest overall outcomes, because the amount of load or resistance is such a low amount, 3 to 5% of your body weight, we can stimulate the tenocytes or the tendon cells, as well as the nervous system, as well as the muscles, twice a day, right? And so if we give you, think about this, 4 exercises: wrist flexion, wrist extension, rubber band extension, tennis ball, and we said 3 sets of 15. For the flexors, you're actually doing in the morning, this is 45, and then you do another 90 for the flexors, and then at nighttime you're doing another 90 for the flexors. That's cumulatively that you're doing 180 reps every single day. Yeah, that's high volume. That's what it takes. Now, not everyone can tolerate that. Literally, not everyone can tolerate that, which is why we always literally work with the individual to say, what are you feeling? Do you feel like it's cumulatively increasing? If so, let's take the 3rd day and only do 1 time. Or if we notice that after 2 days it's starting to increase, let's do 2 days on, 1, 1, 2, 1, 1, 2, 1, 1. Or we say, hey, you actually don't even feel strain, but you just feel more symptoms. Let's just do 1 time a day. Or, hey, let's rest more. Does it seem to go away? And generally, over time, as we can get to that higher volume, it just leads to faster overall outcomes. So hopefully that answers the question. Then we go into, ooh, me a do. So without those features, you would consider the pain most likely just soreness or something you should work through. So what I'm assuming here, ooh, me a do, or ooh, me a do, is that you're asking about the level of strain, right? If we exceed that or we don't exceed the 5 to 6 sharps, those sharp that consistently sharp when you pick up everything I said, and it's below that, then it could be soreness. Sure. It could be sensitization. We don't know. It's not just, yes, you should work through this. It's, okay, well, I know why you have elevated symptoms, because in the past 5 years, every single time you've experienced this, you felt a 5 out of 10 pain and you thought that that was dangerous. And that sensitized your nervous system. It upregulated the signaling to your spinal cord, and that upregulated the signaling to your brain. And your brain is starting to develop these other connections to create danger signals whenever you are in that specific context. So I would say in that case, well, you can, but we had to do it in a graded exposure way. Now, the other way is like, well, hey, you didn't have that past experience, and it is just soreness, and it was cumulatively because of yesterday you just went, you picked up something like this and you felt it. Then we would say, yeah, let's see what happens. How does it feel? It feels better. Feels worse. Why does it feel worse? Let's figure it out. Do you see how it's not just a single answer for any of these questions? It's, okay, well, I got it. Now, what are the 7 different variables or 4 different variables or 3 different variables that led to the elevated symptoms, right? Is it, oh, I did a lot of exercise, or, oh, I typed more, or, oh, I used 7 more thumb binds, or whatever. We actually have to figure it out so that we can say, yep, I know why I feel more symptoms. And I can safely continue because whatever, XYZ, I know I'm safe. I didn't damage myself. It's underneath the level of strain. The past 6 days, I was able to do more. It's nuanced. So I would say we can't say it's yes and no. It depends on your situation. And we need to evaluate and determine what those variables are so that you cumulatively build a mental model of how to make better decisions over time. I don't know if that makes sense, but hopefully it does. All right, now, how about, ooh, bitches eating dog food. Okay, I'm sorry. Sorry, this is the name. So I'll say B eating dog food. This guy's main problem is this, and sometimes he feels pain at the 11-minute mark and then it comes back. Okay, so sorry if anyone is offended by bitches eating dog food. I didn't, whatever. Elliot, you can, if you want to make a comment about this. I don't know.
Doing the irritability index and being able to increase the amount of time I use the keyboard, but can't seem to make it past 11 minutes. Sometimes I feel pain before the 11-minute mark, but it goes and comes back. So I would need a lot more context here about what else you're doing. But like I mentioned earlier, when I introduced the idea of general endurance and specific endurance, typically we use that irritability index to calculate out how much specific endurance you should be doing. You should also be making progress with the general endurance exercises simultaneously. So we're able to continue to scale the general endurance, which feeds the specific endurance, and then specific endurance feeds back into general endurance. So both are progressing at the same time. Assuming that you are also doing the progressive overload for the endurance exercises as well, and you're kind of like really plateauing still at that 11-minute mark for activity, then I would want to look a little bit deeper into kind of what your sensitization profile looks like. I'm assuming if you're asking here, you're not actually working with one of us at the moment. But that's kind of the line of reasoning I would want to go down, is to see what other factors are contributing to this increase in sensitization, whether it be maybe your beliefs about the pain that you have, or the past experiences that you've had with pain and things like that, to really kind of dive in there to see where this mismatch is between kind of the experience that you're having and then what the actual physiological reality of your tissues actually is.
And so when he says sensitization profile, this is like one slice of it. It's basically our pain questionnaire, which is like, hey, it's called the fear avoidance component scale. It helps us understand how you think and respond to different scenarios and your fear and your avoidance. And this is just one slice, right? People might catastrophize or doom or ruminate or think about the pain or think that must be damaging something. And those all influence your pain. Unfortunately, they all do. And so what we need to actually be able to do is understand what you're thinking, and then change that. We literally have to do cognitive behavioral therapy, work through a basic understanding of pain, help you understand the physiology of how pain is involved so that we can, oh, why is it? Oh, there. Oh, nice. How we can actually help you change those beliefs or feel safe in doing what you need to do over time. So yeah, that was good. Valfreya again, she says, I was curious about the need of increased protein and creatine for endurance training. We have a registered dietitian. I don't really have like a specific like data set that I would reference to say, oh, for sure, if you hit over like 0.8 kilograms per kilogram or grams per pound, you definitely make faster progress. All we know is that, hey, when you have at least collagen supplementation of vitamin C, that can sometimes support the adaptations that occur with tendons. Creatine in general is just the greatest supplement ever studied and in the world. It's beneficial in all ways, not just physically but cognitively. I would say like there's no harm in doing more, but I wouldn't expect any significant outcome by mega dosing or being consistent with your protein versus not consistent with your protein. Maybe just the general habits and lifestyle issues around inconsistent consumption of foods is leading to hormonal issues that are causing problems. That's more of an issue than just like, oh, I'm not hitting my protein macros. Yes, the answer to this is yes. That's the answer. Yes. Similar soreness.
We
yes.
have an add-on about nutrition for tendinopathy that goes into all of the best practices, and it was written by our dietitian, and also supported by what the current research says in the practice acts for the athletic training association. So I would check that out on the website in the add-on section if that's something you're interested in diving more into. They're all kind of laid out there, but it's really nothing crazy beyond the basics of just making sure you're getting enough protein for your body weight and then using collagen supplementation.
All right, Mr. Sinclair. Mr. Sinclair, Brett, maybe you can answer this question. Do you think it's better to build up strength to use a standard mouse, even though all the ergonomic folk view it as terrible? Or is a vertical mouse better for long-term health?
Yeah, so you could really dive into ergonomics and nitpick every single thing, but ultimately, if you want to do something in a particular way, as long as you have the capacity for it, and you're wanting to play it that way, or you're wanting to use a regular mouse, standard mouse, then we just have to know that I need to train these specific muscles that it's working the most in a meaningful way. And by trading out the mouse to more of a vertical mouse, well, we're just going to distribute or change what muscles, what tendons we're using for that. So it's just a trade-off at the end of the day.
Yeah.
And yeah, I mean, truthfully, you just need to train what you're using so you have the capacity in store for it.
I'll give you guys an example. This guy is a professional Counter-Strike player, and he came to me and he said he held his mouse like this. Can you guys see? He literally would hold his mouse like this, okay? Where he lifted his middle finger up, plays 8 to 12 hours every single day, like this, okay? His pain was here, right here. And I didn't say, put that finger down, sir. Instead, I said, well, I don't know how the culture is over there, but we don't keep our middle finger up. But I need to also understand your capacity. And he had terrible capacity. And what we did was we built up the capacity for him to handle that, because his life, he was like, I got used to this way of aiming. I know that over an 8-hour gaming session, my HP loss per unit time is 3 versus if I just put that finger down and stop flipping everyone off. I'm okay with that. Okay, well then let's get your HP to 20K. I did it. And he got better. Okay, so the answer is exactly what Brett said. Build up your capacity. There you go. Problem solved. I like someone said, it's scary because you think doing this will cause more pain. And that's exactly the harder part of often that we find of like, look, I understand this. I understand that I'm safe, but I don't know how to implement this. And this is why it's so important to have a healthcare provider that understands pain and can teach you and speak to it. Because think about the guidelines that your physical therapist or your occupational therapist gave you when it was exercise. Was it, hey, feel 2 to 3 out of 10 pain? That's fine. Anything more than a 4, you should definitely stop doing it and then come back and we'll make some changes. How does that make you feel about 4 out of 10? And it's probably really dangerous. Or, they might be like, any pain, you should definitely not keep going, no matter how much pain. That's a lot of people. It's like, you shouldn't be feeling more pain. This is bad. And so it creates this perception that, one, pain is how we track progress, which is absolutely useless because pain doesn't tell us anything about the tissues. And 2, we focus more on pain and it doesn't even represent the level of strain that we defined. Okay, so I know it's hard, but it requires you to find someone. Hey, do you understand pain science? What is your understanding of pain science? Can you help me understand what's actually too much within the context of what I'm feeling? If they can, you found the right therapist. If not, consider we have limited slots, but we have people that apply every single day. I'll tell you guys a little bit more about that after all the questions. But yeah, hopefully that helps. I don't know if it does. My back burner 6 TIFO. My thumb clicks when I do a thumbs up with no acute pain, but will feel aggravated. Should I do exercise or should I get what? Should I get resty? Should I get thrifty?
What did you copy and paste?
My thumb clicks when I do a thumbs up with no acute pain, but feel. What exercise should I do? So it depends on where. And I'm just going to say, okay, well, we have this anatomy thing here. If you feel it on the palm side of the thumb, it's going to be thumb flexion based exercises. Tennis ball squeeze, very good. Cup squeeze. If it's on the opposite side, you can do a rubber band, and there's different ways to do it. You can do rubber band extension here. You can do thumb extension. You can do rubber band extension with the thumb going down. That's more on the outer part of the thumb. And so you would build up the capacity, maybe after you do initial tests, or you can start conservatively 3 sets of 10 to 12, then wrap it up. But the idea is it probably clicks because it doesn't have capacity. And just in general for you guys, clicking often is associated with stiffness or tendons rolling over certain parts of bone, or even like gas being released from joints. I wouldn't worry too much about it unless it's consistently sharp. Most of the time it's not. And most of the time it completely goes away. I have so many testimonials of individuals where it does eventually go away. Everyone's different. Okay, we did it. Oh, now let's go on to the next one. Are you guys recording or interested in publishing from your patient panel? Yes, we are. We're definitely looking forward to hopefully working with a university. We have had these conversations before, but we just didn't have the time to really pursue them. But we have published like editorials, we published some textbooks. We're trying to publish consumer-sided textbook soon. But man, we are busy. So we haven't had the time to pursue that. Once a person's pain is improved and they stop working with you, oh, such a good question, Miss Freya or Mr. Freya. This is great. Once, do you recommend they keep doing the same exercises kind of indefinitely, or just increasing the weight and reps as time goes on? I'm gonna answer this
casually doing wrist curls for 100 pounds for 60 reps.
Right. Yeah, definitely don't need to do that. Now I'm gonna answer it, because I, in the past week, have discharged 2 or 3 people. This is exactly how I help them understand this. 1, if you want to do a certain level of activity, let's say it's 8 hours of work plus 3 to 5 hours of gaming, you need to maintain a certain level of endurance or capacity. In order to do that, because right now you're doing it 2 times a day, 6 to 7 times a week, let's start to taper it. 6 times, then 5 times, then 4 times, then 3 times. Now, 3 versus 5 times depends on you. If you want to play a violin on top of the 3 hours of gaming 6 times a week, and you want to go bouldering, or you want to just, do finger handstands for no reason, then we got to build that up to more, and the capacity needs to be higher in terms of your percentage of body weight. So it depends. It depends on you, but we taper down so that you maintain it at certain times when you're more busy. And then it gives you opportunity to use the other free time to do other exercises to support the rest of your body, which many times people are like, "Ooh, I also have knee stuff. Ooh, I also have back stuff. I don't know why." But now that I understand that if I don't do anything for 6 years, my back, my knee, my jaw, my toe, my eyebrow, that all gets weaker, right? And so it's like, let me build it up. Yeah, okay, it starts to make sense. So obviously, what you learn when we work together is not just what do you do and how do I think about pain. It's literally, I now understand more about my body. I can now make better decisions around what I should do now in response to what I did. And I know that if I want to have 8 hours of game or 8 hours of work plus 3 hours of gaming, I need to do this. Man, what a great response. That's good job, me. That was really good. Can I ask a question? Or are there no donations? Don't give me any money because we're just answering these questions. Don't fucking donate anything. I'll send it back. There's okay, so can anyone can ask you should just put it down in case. What? I had a rotator cuff injury in 2022. Okay. This is by JDK 5744746. Elliot, you can answer this one. Let me just see if there's any additional stuff. Oh, I just want to do my job in IT and play Zelda and Pokemon on the weekend. Actually, you guys should all play Final Fantasy Remake. I'm so into that right now, and I've been telling everyone. Okay, and then I'll just pull up these other questions. Elliot, I don't think there's any additional stuff, but maybe you can answer this. The question is, I had a rotator cuff injury in 2022. When I play and move my wrist in ulnar deviation, it shakes extremely badly. I'm wondering if that's because of the old injury not healing or a new one.
Well, I don't know if I have enough context to fully answer that, so I'm going to answer it with what my suspicion is. So when you have a rotator, like the rotator cuff is responsible for rotating your arm kind of into internal and external rotation like this, like this movement of the shoulder backwards and forwards like this. So when you're at your side, it looks a lot like kind of moving your hand side to side on the desk. I'm assuming when you're talking about ulnar deviating, you're also like talking about, I'm making a lot of assumptions here. I'm assuming you're gaming and rotating externally when you're aiming this way. So when you have an injury, and specifically if it's a tendinopathy, which a lot of rotator cuff injuries are tendinopathies, the whole foundation of a lot of the research that we use to actually treat repetitive strain injury comes from the work of Ebony Rio, who proposed this model of tendinopathies not being just a endurance deficit, but also a motor coordination deficit. And there's a feedback loop that happens when you have an actual mechanical cause of a tendinopathy that causes it to get worse as the brain kind of forgets how to do the movement pattern effectively, to send the signal from your brain all the way down to the nerves, to the muscles, and it doesn't recruit the muscles the way it used to. So some muscle fibers will fire first, then other muscle fibers will fire, and it creates this mismatch that leads to uneven strain, which ultimately loads the tendon more and kind of snowballs these tendinopathies. But if that was never truly resolved with the external rotation of the shoulder from this rotator cuff injury, it could be presenting as kind of a coordination deficit, which is kind of what that shaking indicates when you're ulnar deviating now on the mouse pad with the arm. Again, I'm making a lot of assumptions here.
I think they're all right. They sound very accurate to me.
Unless you want to clarify any of that, does that sound about right, JD?
Okay. While we wait, any thoughts on adjuncts you've seen or heard to be helpful in expediting recovery? Prolotherapy, acupuncture, NSAIDs. Brett, why don't you take this one?
Yeah. So, in therapy, you might go into a clinic and you'll have your therapist, do fluidotherapy, do red light therapy, ultrasound, this, that, acupuncture, dry needling. I think those can be add-ons, simply put, but I don't think they replace the need out of doing your exercises, right? So exercises, yes, are are ultimately the building block in helping you to build up that HP. And now if these tools are helpful for you in recovering from the stress that you put on, I think they're great. But maybe not everyone has access to them, and I don't think they're required in many cases. So I think it's person dependent, and there is some good research at times with some of these. But yes, I mean, ultimately, I think you can be fairly bare bones in your recovery process as long as you have the understanding of pain science and you work through your endurance using the right exercises. And now exercises, yes, they matter, but the prescription of them matters as well. The dosage, I guess I should say. So you have to find the right dosage that is working for you. And, if it's too much, that's causing some soreness that is preventing, you from doing, your functional activities. We could play with that as well. You could always look at increasing rest periods or, scaling back if we are pushing too much, but yeah, ultimately it does depend a little bit on that.
Yeah, exactly. Basically, all of these adjuncts target the source of the pain, right? Which is the tissues or inflammatory processes. So it doesn't address the cause. So they're adjuncts for a reason. And so we can sometimes leverage them to create safety where, hey, I use a brace or I use an NSAID or I use a compressive sleeve as I'm doing graded exposure so that it feels better. And then we can confidently say, look, I did 2.5 hours every single day this past week when historically 6 months ago, I was only able to do one. And now I use the brace or I use the compressive sleeve 6 out of the days. And then 2 weeks later, 3 days. Another 2 weeks later, 1 day. And I barely use it. And then we progress to 3 hours, no sleeve. And so we can do the same thing with NSAIDs. And ideally, we obviously wouldn't have you do it every fucking day, but you guys can hopefully understand the concept of how can we leverage these effectively. Now, acupuncture, to be honest, like I understand the benefit. Dry needling can be great. It can, be very helpful, and especially for trigger points to really reduce the hyperirritability of certain parts of the muscle. But every single time, I'm telling you guys, every fucking time I've had someone that has done acupuncture, does it create the risk of a needle hitting a nerve? Even if it's 1%? Yes. So, do I want to introduce that risk when it's not even necessary and the best outcome is that it's short-term relief? Not really. I don't think so. But if you find that it's beneficial and your acupuncture is perfect, like every single time I've worked with someone that has been chronic, someone has fucked up and it feels worse for like 3 to 5 or up to 2 weeks. And I'm like, it's not really necessary. You could have just heated it and it would probably be the exact same. So sorry, acupuncturists, no shade, but I don't think it's like a primary modality. Have you ever worked with hypermobility? I think Elliot, you wrote all the content around this. So, I mean, but yes.
Yeah, I have a lot of hypermobility. Let me answer JD's question here real quick. So just to kind of piggyback off of that, he was asking about kind of like shaking and juddering with kind of ulnar deviation. And he was saying that he's not sure if it's coming from the shoulder or the wrist. If you had an old rotator cuff injury that was never, he said he's done exercises for both and neither have seemed to help. But so we use the metronome when we prescribe exercises because of this brain to muscle connection. Not only does it keep you on pace when you're doing the exercises, we use a metronome set to 50 beats per minute when doing exercises. So each tick is when you initiate the movement in either direction. And we use this metronome because the research shows that it helps to normalize the signal coming from the brain through that external auditory stimulus. And then it sends a more efficient signal through the nerves to the muscles and helps the muscles contract more efficiently. And it ultimately will help to resolve that kind of shaking issue that you have going on there. There's a whole lot more going. This is a very complex question that I don't have a ton of nuance to answer fully for you here. But that would be my biggest recommendation is just start trying to train with a metronome, do the exercises you're already doing, but start using that metronome at 50 beats per minute to try to normalize that movement pattern that seems to be giving you issues right now as far as like smoothness of movement goes. Okay, next question.
The
Have you worked
hypermobility.
with someone who's hypermobile and it's causing them issues? Yes, I am hypermobile. I can bend my thumbs backwards. I
Me
can
too.
dislocate my thumb joint like this.
Boom.
It's disgusting. I
Boom,
can bend
boom,
my elbows backwards. My
boom.
knees
Same
bend
here.
backwards.
Same here.
I can do one of these guys right here. And as a physical therapist, this actually presented me with repetitive strain injury problems because I was such a heavy manual therapist for a long time. I'd be doing 8 to 10 hours a day of deep tissue work because that's what my clients
He
were
likes to
coming
touch
to me
people.
for. I do. And
Perfect.
that led to my own set of issues, specifically de Quervain's veins in the back of my thumb here. I'd have days where I'd have to come home and ice my hands in buckets of ice water because it was so bad. Until I started doing my own rehab exercises and following all these protocols myself. And then I never had any issues anymore after that because I built up the endurance capacity to handle that. But I would notice that if I would get like sick for a couple of weeks and not be on top of doing the exercises and not on top of going to the gym, I would notice that pain would start to creep back up really quickly because I wasn't keeping my hands at a level of endurance to handle that really heavy manual therapy load. And because I'm hypermobile, it means that I have to do more work to stabilize my joints because they lack the passive stability of those ligaments. The ligaments are looser, they move around more than they should, the bones aren't as tight together as they should be. But by compensating for that, by doing the continuous endurance exercises, by making sure I'm staying in the gym and doing the isometric holds of the barbells and the dumbbells, I'm actually able to keep my hands at a capacity that was allowing me to work 8 to 10 hours a day consistently without pain.
Yep. And then for Mario, Morgan, Giles, what do you mean in terms of like context? Like just generally chronic low vitamin D? Like, are you doing supplementation to address the deficit? You know, have you been getting enough sunlight to address that? And like, what is your understanding of how low vitamin D would influence your RSI? Maybe you can help us understand that. Now, in terms of the equipment, I wanted to highlight everything that I just responded with. Very good for finger flexors and some extensors and your thumb flexors. We like regular rubber bands and the preset ones that you can buy because, look, if this is too hard, let me take one off. If this is too hard, let me take one off. If it's too easy, let me just add more. I can infinitely progress and regress. Now, the preset ones, and I've had patients that jump from 8 pound to 11 pound and they actually flare themselves up because it doesn't grade the exposure in the way that we would like it. So, Brad, I don't know if you have the adjustable dumbbell.
I
You
do.
have that? Yeah,
I was just
showcase
gonna
that.
show that.
The
That's why I have
greatest.
this.
I love this because
And I can do ulnar deviation
Oh
for
yeah,
that.
look at that.
Right there. I can
Boom.
put it back on and I can adjust the weights. Oops. It's just a very easy. I'm not making it look easy now. And I can take it off and load it however
Not
I
sponsored
want.
by 1HP, by the way.
No.
Yeah, we're not sponsored. So whoever made that, you're welcome.
But it can go from 2 to 7 pounds. So I can load, one fully up versus one smaller one.
Okay. And then if you do extension exercise, should you be doing the same amount of flexion exercise? Generally, yes. Extension is typically a little bit harder because for all group related movements, because group is a composite movement, we're using our extensors as well. So it can often fatigue while you're doing the flexors, and depending on your mobility, you can even pull on them. So extensors are typically harder for some people. But yeah, we like to build both sides in terms of strength because you need both flexion and extension to grip and perform these fine motor activities. And then we have a question relating to our program, which is, can you explain the powerlifting program? Oh, whoa, what happened here? Can you explain the powerlifting program and the 1HP troubleshooter? So that's our only program. We only have this program now. We don't have any tiers. And basically the way that it works is you get your outcome of getting to 100% or you don't pay or you get your money back. And our goal is to work with you until you get to that point. The details of how it works, which is basically we meet every single day, or not every day, every week. It can be more, it can be less. We give you exercises, we teach you about pain, we gradually integrate that understanding of pain over time. And our incentive is aligned with yours. We want to help you get better as fast as possible. so that we can help more individuals with chronic and persistent wrist pain. Traditional care will say, hey, I'm going to see you session 1 and I'm going to do evaluation. And then I'm also going to do manual therapy and I'm going to do ultrasound and I'm going to do heat. And I'm going to charge for all these things. And then session 2, I'll do ultrasound, heat, and I'll charge for therapeutic exercise too. And every single time I'm going to charge for that. Now the incentives is that as long as we keep having them come back, we'll keep charging. And oftentimes it can get pretty expensive. And this is just PT. It's not OT. It's not OT. It's not orthopedic surgeon visits. It's not surgery. It's not MRIs. It's not X-rays. So it can add up, and the incentives are not even aligned. They don't care if you leave. They're just going to see someone else that will come in and do fee for service. We work with a value-based care model. There's no tiers. You just pay for the outcome. And I'm sure everyone has already seen it online. It's $5,000 one-time payment. Depending on the individual, we can work with the individual to break it up in ways that make sense for them. But generally, it's the one-time payment. And it's because we always get the outcome. Now, my pain,
I've never seen an orthopedic surgeon offer a refund on their surgery if it didn't work.
Exactly. Exactly. My pain is in the thenar region. It's been 2 months. Where can I find exercises? I'll go on YouTube. I'll go into our free guides. You can see and learn everything about the specific exercises. It's typically going to be the thumb flexion exercises and thumb adduction exercises. So YouTube, we have a 7 science-based wrist and hand exercises that I created. There's also like 39 different routines that help you learn specific to that region. There's the thumb ones. I will look into those. Our guides are specific. We have our case study library that combine our guides with case studies specific to pain regions. And all of those, like, let me show you it to you guys. Like, it's all free. Again, this is all free information. Right, 1 HP case studies. Okay, so look, oh, my pain's here. So then these are the case studies of people that we worked with. These are them telling us about it. This is how it worked. This is them progressing it. And then these are the exercises that you can do. This is how you choose the right ergonomics. This is the stretch, the endurance exercise. If you want to work faster, you can book a call with us. It's always about speed. For us, it's like if you want to get better faster. Oh, I like this. I like the sunlight in the back, Brett. If you want to work with us to get faster results, and again, I don't think anyone can beat our outcomes. That's why people pay for it. And you know, we don't work with everyone. I want to make sure that you guys understand this. What we like to prioritize are individuals that have had chronic and persistent pain for up to 6, 7, 8 years, multiple years, sometimes 2 to 3 years are the lowest ones. And they've seen multiple physicians, multiple specialists, failed surgeries, multiple images, some found stuff, some didn't. And we want to prioritize those because those are the highest need. They literally have no fucking clue what to do next, and often are pretty in a pretty difficult state in terms of their understanding how they can continue with their life, their hobbies. We prioritize those first, and we have a few slots here and there where we help more like subacute. But the reason why we create all these free pieces of content is because we truly believe that you just go through this, you can solve it all by yourself for the subacute and acute cases. We literally have, you know, we have all these videos. I've spent the past 11 years doing this and Elliot with me for like 8 years, Brett with us for 6 years. Like, we've literally created at least 20 to 40 hours of content that will teach you step by step exactly what you need to do if it's acute and subacute. And then chronic, it's hard, right? That's why we offer this program, to give you speed, give you access to just resolving it faster. Now, I don't know, hopefully it answers the question. Thenar, okay. All my fingers or thumbs are for hypermobile. What would you suggest? Okay, so this is the hypermobility question. Elliot, what would you say here?
I would suggest building up the endurance to handle the hypermobility.
Exactly. Okay.
In a nutshell.
Yeah.
If you want to draw out a graph, Matt, showing like the amount of like active stability demands and then passive stability demands, and then draw a big X through the passive stability, and then you need to like increase the bar of the active stability to raise it up there. Yeah, so the bottom part would be the passive stability. The top part would be the active stability required to finish your 8-hour day.
This is
And
muscles and
then,
tendons, zero
when
ligaments.
that passive stability goes down because you're hypermobile, then you need more active stability. And you get that active stability by building up your endurance of your tendons to handle that decrease in passive stability.
Okay, now,
Great job.
wow, great, concise answer. Eric, 90,000, over 9,000. Any
What,
recommended
9,000? That can't be right.
Any recommended exercise to ulnar nerve irritation coming further up the neck and shoulder? You might have seen Elliot's or my case studies on TOS. You can actually check it out if you want. Again, it's free to learn exactly what we did. Let's see, these are an extra case studies. TOS. How do we do it? What do we do? What are the exercises? What's the science behind it? And so the idea is, yes, we have to identify where the nerve is getting entrapped. Now let's do a quick education. There's typically 3 sites that we like to look at. We'd like to look at the costoclavicular, which is between the first collarbone or first rib and the collarbone. That's where
almost never the problem. It's
Yeah.
always the pecs or the scalenes.
Yeah, exactly. And then the second is between the scalenes, which is between these 2 scalenes here, two muscles here. This big branch of nerves comes out, and then underneath the pec. Now we can do specific tests to identify it. General tests like the Roos test can put them all in a specific entrapment position. So you have to look into it specifically to say, okay, hey, when I put the pec in a compressive position, and when I do a diagnostic intervention, and again, I'm talking really fast, but hope if you need clarity, the idea is like we can assess specifically, and physical therapists should have the ability to assess specifically. I want to check here. I want to check here. I want to check here. It's for sure here. And this is the evidence that I know is coming from here. And these are the impairments. I have tight upper traps. I have poor serratus endurance and control. I have excessive lat tightness that pushes the scapula down, that leads to irritation here. They should be able to figure that out, guys. Please, for the love of God, if you're a physical therapist, get better at fucking solving these problems so that we don't have to treat them. It's not hard. You can just do an objective and subjective assessment to determine what tissue is involved and what's the contributing factors. Now, once you identify those things, then you work on it. Hey, how much are you sitting? What sitting positions are leading to you feeling this increase in symptoms? Is it because you're dropping your right shoulder over for an extended period of time? Well, we have to change that. Okay, how's that leading to overall amount of tightness and stiffness and weakness? We have to address both. Okay, now what about the habits? You've been sitting for 8 years, for 6 years in a row, and then you started to feel it. It's not because just the sixth year you started to feel it. It's this accumulation of lifestyle habits that led to you getting weak, getting stiff, getting tight, putting pressure on this nerve. Do you see how it's not simple, but it's complicated? We have to address it, identify what's going on, treat those things, teach you about pain, teach you what's too much, why it's normal to have more symptoms in the beginning as you're doing more exercises, potentially irritating in the short term, but not doing so much pressure that it will cause you to have your arm go limp. It's pretty impossible unless you're just forcing it there and never moving for like 6 hours straight. So I don't know. I think that answers it. I think that did a pretty good job in sort of like TLDR, giving anatomy, helping you understand what you would be able to do. Check out a case study. You'll learn the exercises. You'll learn how to think about it. Woo! That was pretty
I also
good.
have a really great video on TOS if you want to check that out. It's on the YouTube. It basically it goes
Elliot
through all
actually,
this stuff, but more
yeah.
in depth.
Yeah, Elliot covers it all for free. When do I worry about carpal tunnel syndrome?
The carp tunnel.
Well, it's almost never carpal tunnel. We talked about this. Now, here's why you can feel nerve numbness and tingling. Well, what happens, and we even talked about this earlier, what happens when our little tendon cells, they experience too much load that they can't handle? Well, they reactively swell. Water, proteins, proteoglycans, they go into the tendon swells, it reactively puts pressure on local nerves. Maybe the tendon itself has some nerves where it can put pressure there, and it creates tingling that's either isolated or extends further down. Now, if you treat the carpal tunnel symptoms, I should rest, I should brace, I should not do anything, I should cut the ligament. Well, you're not treating the underlying problem, which is, look, your tendon cells cannot handle the capacity. So treat that. And maybe treat the other factors. If we draw the pie chart again, hey, am I sitting for 8 hours and not moving and typing and not taking breaks? You should probably move more. Is my capacity only 1% of body weight and I need to increase that to 3%, then 5%, and then I should be able to handle it? Do I understand that when I am doing this, I can put temporary pressure on nerves that might cause tingling, but it's not dangerous? Yes, these are how we treat this. And it takes comprehensive, collaborative work to help you feel safe, that you are not damaging anything. The tendons aren't inflamed, they're just irritated, or they are in a state of being reactive where there's swelling, and that's not even from inflammation. It's not an inflammatory process, it's mediating that. Woo, okay. Are you saying that you guys prioritize it because can get better? Yes, exactly. What we're aiming to do is like, hey, for most people, we want our resources to help them get better, but we don't have the time. Like, we literally are trying to help as many people as possible. First, by creating this wealth of knowledge that hopefully teaches people how to step back, think differently. Maybe the healthcare system isn't perfect. Maybe I've been trained from seeing the doctor every year of my life into believing that they know everything. And once I can understand that, then let me actually understand what's going on. Then build it. Build this program for yourself. It might take longer than if you worked with us, but still, you can get better. And I would bet there's many individuals that have gotten better, and they just don't show up to these because they're living their life, right? And there's people on our comments that have told us that, right? And so we also prioritize them because like some people are in really dark places. And look, you can tell I care. I literally fucking care so much that I made this our entire business, right? We literally want to help these people that are struggling, that are in this place where they literally can't pick up their kids. They're thinking about really dark things, and we get them out of that. And in a way that doesn't require them to go through more surgery, more imaging, more belief that they have this underlying spondyloarthropathy or whatever, some sort of rheumatological condition that no one has been able to figure out. That's why we focus and prioritize our effort, because these people are really fucking struggling. And it's like really sad. And we literally, there's 3 of us. We can't help everyone.
Only so many hours in the day.
What are the best way to build endurance? Rubber bands, hangboards? Not even. Void walker. You just do the exercises and you do them with high reps. That's how you build endurance. And you start with no weight, 1 pound, 2 pound, 3 pound, 5 pound, up until 5 to 6% of your body weight. Just increase. Dumbbells. That's all you need. Dumbbells. Yep. Would you love to?
Rubber bands help too.
Yeah. What can I do for my thumb wrist issue? It's been feeling stiff and thumb feels inflamed in the tendon. My wrist pops whenever I extend my fingers. I can't. Okay. So Hobozo. This can be our last question. I got to go pick up my daughter, and then Brad has to move the rest of his stuff. And what can I do for my thumb and wrist issue? So stiff. Do our exercises and then learn more about pain through our exercises. Start small. Start with 3 sets of 8 to 10 and do it every other day if you feel like it starts to inflame it, or do it every 2 days. If you feel like you can tolerate it every day or twice a day, then try. And then reference our level of flare up, or the line of that we mentioned in terms of what's too much, to help you make decisions on whether you're strained or not. So do your exercises, and also zoom out and say, like, what am I doing on a regular basis that might be using my wrist and hands more? And maybe modify those things in the short term. Temporarily reduce gaming, temporarily reduce phone use, temporarily reduce chopsticks, whatever they might use your thumb, from 100% to 75% for the first week, then 80%, then 90%, then back up as you get to the 4 to 6 week mark when there's more adaptations. Whew, okay. Okay, let's do, this is truly the last question. Valksar, someone else answer this. I had an issue with a pinky for 3 years, cubital tunnel syndrome, 24 sessions of PT. Now another EMG said it wasn't. You might not have been here for the beginning of this, but definitely check the recording. For carpal tunnel, it's just giving me all the numbness of the cubital tunnel. Wait, what? It's not either cubital or carpal tunnel, but it's actually giving me all the symptoms of cubital tunnel, but the numbness. So probably like pinky sided forearm pain with maybe like hypothenar pain or pinky pain. One of you guys can address this.
If you have the numbness, the tingling, the pain in the pinky side here, that's enough indication to know that the ulnar nerve is being compressed. Where it's being compressed is much more likely the forearm flexors than true cubital tunnel syndrome, which would be kind of classified by some kind of anatomical abnormality through that cubital tunnel. But the flexor digitorum profundus, the flexor digitorum superficialis are both muscles responsible for wrist flexion, and the ulnar nerve dives right between those. It makes like a sandwich between those nerves. So when we have one of these repetitive strain injuries that is primarily focused on the wrist flexors, oftentimes what goes along with it is that ulnar nerve compression. So it's very, very easy to see these ulnar nerve symptoms in flexor tendinopathies when the flexor muscles are irritated. If you highlight that ulnar nerve right there, you see how it was kind of sandwiched between that superior flexor and the deeper flexor. The biggest thing that you can do for cubital tunnel syndrome outside of some kind of like crazy abnormality that if you've had all this testing done, I'm sure they would have found by now, is to actually normalize the endurance of those flexor muscles and tendons, build up that endurance to the 5% of your body weight for wrist flexion, using that metronome, getting to the 60 reps, to actually take the chronic compression off of that ulnar nerve and ultimately resolve those symptoms.
Exactly. Last thing
That's
I'll
it
say
in a nutshell. And I also have a video on that.
Exactly.
I have a video on all of these pathologies. I'm a pathology guy.
Yeah. I want to make one last statement, which is like, this is to all the doomers in Reddit that feel like they have no hope. I challenge you to try to step out. I know it's so hard because your n=1 experience has given you less and less and less hope that something's possible. But through a lot of what we've created, through a lot of our content, we've shown that it is 100, not even 100, 1,000% possible to get back. And that the only thing that's holding you back from recovering is your belief that it's permanent or it's not going to get better. And just flipping that, like I dare you to kind of think differently and see what happens. And if for some reason you still can't get around to that, I would love to chat with you. I would love for you to come in here, ask questions, and we can show you exactly what is holding you back. I will take an hour to, in front of the whole world, explain and make it clear why you would still be dealing with what you're dealing with. It's not this systemic tendonitis, systemic inflammation or medication that's the problem. It's not that, tendinopathy is permanent and you'll never be able to use things again. It's all the pie chart that we just described. Okay, come on, doomers, let's go. I'll challenge every single one of your beliefs. Let's talk. But every single time that I have, I'm met with no response. In fact, and even sort of like accusations that this is more or less a scam or we don't know what we're talking about. And so I would love to be able to have a conversation with you to show you maybe the zooming out and thinking more holistically can help you actually get better and maybe spread less misinformation and create more fear in other people when it's n=1. And for us, we have n=9,000 people, okay? In our app, we have 9,000 data points, more than that. So which one would you weigh in terms of competency and trust? That's it. I hope the doomers, we're going to cut this up. I'll leave a message to doomers on my Instagram and on my YouTube because I hope they see this. Anyways, that's all I wanted to do. Anything else that you guys wanted to add?
Nothing on my end.
Okay. Well, as a last thing, if you guys are interested in, applying to work with us, free consultation. This is a website. You apply right here. Like I said, we prioritize individuals that have more persistent pain. Fill this out. We'll let you know if we approve you. But otherwise, hope to do this again, maybe in the next month. But we're going to turn all of these into short answers so people can learn more, see how we think. That is all, everyone. Goodbye.